Hey guys, got a couple questions from some students about this leukemia and lymphoma section coming up, and I thought it would be a good idea to go ahead and give you guys a primer. Essentially, what this is really just the review session that I would have done at the end of the course, and I'll still do, or at the end of this block. But what I did was I went ahead and did the lymphoma and the leukemia learning objectives, and so I'm going to just go ahead and give you a brief overview now, really informal. But you guys should be able to watch this and have a better idea of what to study and what we're looking for moving forward. So this first one's on just the lymphoma section, and this is two lectures that are going to be given by Dr. Yared, and they really are two of my favorite lectures. So we'll go ahead and get started. The first objective is describe the terminology and definitions used to classify these white cell neoplasms. And really what you got to do is break it down into two different groups in your heads. You're going to have the leukemias and the lymphomas. And we're talking about the lymphomas here. Inside those two categories, you're going to have B and T cell. Now there's other things that can come into play, but in general, just remember B and T cell at this point. So you can have B and T cell lymphomas and B and T cell leukemias. And really the names are kind of helpful. Now they're long and they can be kind of drawn out, and I get that. But if you look at the names, it tells you exactly what's going on. So let's take two of them first. Acute myelogenous leukemia, which you're going to definitely need to know about, and chronic lymphocytic lymphoma, which is another very, very common disease. And if we compare them side by side and you look at the two words, first words, acute and chronic, basically that tells you what kind of cells are making up the malignancy. Not in B and T cell arena, but basically if it's immature cells, it's going to be an acute, or if they're blasts, and those are bad. I mean, they're pretty highly aggressive malignancies that usually happen in young people or older people that have a chronic myeloproliferative disorder, as we'll talk about. The other one is chronic. This means that the cells are matured. In other words, they're terminally differentiated. So they're lymphocytes, B or T lymphocytes, and they're pretty easy to identify. Next, you go to myelogenous or lymphocytic. If it's myelogenous, it's from the myeloid cell line, which we'll talk about. Lymphocytic, clearly, they're lymphocytes. They're lymphoid in origin, usually coming out of the lymph nodes. And then you have leukemia or lymphoma, and that's usually how the name ends. If it's leukemia, it originates in the marrow and then kind of trickles out into the blood, whereas a lymphoma originates in the lymph nodes and stays usually in the lymph nodes and can occasionally go to the bone marrow. So when we talk about the WHO classification system for the white cell neoplasms, the reason that this is a learning objective is because a few years ago there used to be something called the FAB, or French American and British classification system. This is gone by the wayside. This learning objective is still important because you're going to see these other names out there, but what we want you to know are the ones that are in the textbook. So if it gives you a name in a textbook like acute myelogenous leukemia with a T1517, that's the one you need to know, not acute myeloid leukemia M3 variant, which is going to be the old nomenclature. And you'll hear that thrown around a little bit, but that's why this is an important learning objective. And Dr. Yard will cover that pretty thoroughly. When we talk about CD markers and how they apply to the neoplasms, these are, as you guys know, receptors that are on the cell. And one of the great things is that we can use something called flow cytometry, where we line the cells up and we analyze their receptors that are on the surface. And from there we can kind of tell exactly what's going on. And so we use these markers to help tell us what kind of lymphoma or leukemia we're dealing with. And some examples. So if you see a cell that is CD34 positive. CD34 positive is actually a blast marker, so we know that that's an immature cell. So we would say that's an acute leukemia. CD45, not very helpful because it's seen on essentially every single white cell in the body. But then you get into the more helpful ones, and so you'll notice that you have the next three are T cells, and basically they have low numbers. You'll see CD3, CD4. Those are the most common. Again, notice CD45's in there, but again, not that important because that's not specific for anything. The cytotoxic T cells are CD8, and you guys already knew that, but we can use these to classify them. The other category, the last one, is the B lymphocytes, and their CD markers tend to be higher numbers, like 19, 20, 24, numbers like that. So you'll see that they can be CD45 positive as well, with 19 or 20 and 24. And that's just a general trend. That's not meant to be memorized, but if you see CD markers that are low numbers, no T cell, high numbers, no B cell. Monoclonality in regards to common white cell neoplasms. And this is important because when we look at lymph nodes, it's often hard to tell if anything bad is going on or not. And monoclonality lets us know that there is what we call a clone or a neoplastic group of cells that's starting to come out of that. And so on the left, what you see is a follicular lymphoma. And this is we call it a follicular lymphoma because there's these giant follicles of all these clonal cells, and they get very irregular and large, and they push together, and they basically distort the lymph node this way. And this is not the normal architecture of a lymph node. Dr. Yard will cover that pretty extensively. But that is what we would consider clonal. Another example, this is a cell in leukemia. You know it's leukemia because we're looking at a peripheral blood smear as opposed to a lymph node that we see on the left and the right. And here are two hour rods. So that's a myelogenous leukemia. And then on the right we have a Burkitt lymphoma with the classic starry sky pattern, and there's all the punched out cells. These are histiocytes eating all the cells that are dying as they turn over so rapidly. So these are monoclonal, meaning that there is one clone, when a polyclonal lymph node is actually what you see in reactive conditions, meaning that you have mixtures of different B's and T's cells in that lymph node. There's nothing malignant there. One way we tell is by flow cytometry, and that picture on the bottom right is what we call a flow scatter plot. And you can see when there's a clone, most of the cells stain the same. And so this would be a sign that you're dealing with a clone, is because you have a large cluster of cells and they're almost identical, right? If it was polyclonal, this would be more of a smear pattern that wouldn't have these intense areas of a number of single cells. When we talk about the common white cell neoplasms, including clinical pathologic features, markers, and prognostic determinants, this is actually the meat of this, and this is why there's 2 hours. There's two things that I'd like to draw your attention to. There's a table on 432 and another page 442 that has some additional neoplasms. Now I'm going to go through just these briefly, and this is kind of like the least that you would absolutely need to know, but it's a very good start. So when we talk about all these neoplasms, and this is basically all of them, and yeah, there's some leukemias in here, but hey, repetition is the mother of all learning. That's what my health teacher in high school used to tell me anyway. So first off, ALL, so that's acute lymphoblastic leukemia. These cells express something called TDT, and again, we can tell if it's a T or a B cell based on low numbers, CD markers, or high. And if it stays with our trend, this is usually going to be in young children, which is why you need to know about it, because any disease that affects young children, this is a recurring theme, you're going to need to know. Now, the good thing is that this is very treatable, especially if they have a T1221 translocation. It's a nice number there, easy to remember, 1221, right? They'll have a good prognosis. Oddly, this can start in a mediastinal mass, and so a kid with a mediastinal mass is not going to be one of those thymomas. It could be an ALL, and oddly enough, they spread to the testis too, so that's a strange pattern of spread worth noting. Next we have CLL, SLL. We call it that because it's either chronic lymphocytic leukemia or small lymphocytic lymphoma. They often come together. This is one of the most common that you'll see in people that are over the age of 60. And usually these people just show up and they're asymptomatic. Maybe they're a little tired and a little weak. You do a white count and it's in the 20s or 30,000s, which is high. It can be as 50 and 60,000, but it's going to be high, and they're not going to have any evidence of infection, which should set off some red flags. On the blood smear, the cells are very fragile and they actually smudge, so there's something called a smudge cell. I'm sure you'll see pictures of that. Next we have hairy cell leukemia. This is an interesting one because it's odd. The cells look hairy because they have these little cytoplasmic processes. This is commonly seen in old men with pancytopenia and splenomegaly. This is a very common presentation for this disease. So if you ever have a test question that's an old man with pancytopenia and splenomegaly, the answer is going to be hairy cell. We stain this with an enzyme called TRAP, and so if you ever see something about TRAP positive, associate that with hairy cell. Next we have AML, and we'll cover that more in the next little block, but this is the one you see a ton of hour rods in, so you need to know about it. There's that M3 Fab classification that they have. This is just so you know it's there. but now we like to go with the translocation, and this is one you absolutely have to know. It's 1517, and the reason you have to know it is because these people respond very well with a vitamin A therapy called ATRA, or all-trans retinoic acid, combined with some other things. This differentiates the malignant cells and then they die. It's a almost 80% response rate in these patients, so amazing response for what used to be a devastating disease. Next we have CML, and you guys have already kind of been introduced to this. This is the BCR-ABL, right? 922, got to know that. It can transform into AML or ALL. That's called blast crisis. And they treat it with imatinib, which is an antibody that we've developed to this translocation that blocks this fusion protein. So very important to know about. So here's some lymphomas, Burkitt's. You're going to see that in children, especially African children. If you're talking about the endemic variant, you need to know about the T814C-MYC translocation. Interestingly, whenever you have that 14 involved, and you'll see it here, in mantle cell, and you'll see it down in follicular, that's an immunoglobulin heavy chain promoter, and whatever you put next to that is going to be expressed very heavily. In this case is c-MYC. You don't want c-MYC next to a promoter. That's not a good thing to have, and that's why this grows so rapidly. This is the one with the starry sky pattern. I actually recorded a video for this one. It's not that common, so it's kind of cool to look at, so you might want to check that out. Diffuse large B-cell lymphoma, that's the most common one. Most common lymphoma there is, usually in older patients. It's very high grade, very aggressive, but because it grows so quickly, it responds very well to chemotherapy, something to keep in mind. Mantle cell, you see it in old men. It has a 1114 translocation, and if it's got CD5 positive, that's not a good thing. So we do look for that CD5 thing, and that's, a marker that I would like you guys to know, just because it does portend such a bad prognosis. Next is follicular, which is a very common type of lymphoma. Not as common as large B, but common. It's got the 1418. In this case, what we've done is we've taken BCL2 on 18, and we stick that next to the IgH heavy chain promoter on 14, which causes BCL2 overexpression, which you can see a nice example of in another video. This one is slow growing, and slow growing lymphomas don't respond well to treatment because you need to attack dividing cells. If they're not all dividing, then it doesn't respond very well. Adult T-cell lymphoma, this is very interesting. This could be a leukemia as well, not lymphoma. But HTLV1 infection is what causes this. So this is an example of something that is caused by a viral infection, and definitely worth knowing. Just move that. These people will have skin lesions, and it's usually seen in people that come from Japan or the Caribbean. And then finally we have Sézary syndrome, or mycosis fungoides, and this is a CD4 positive T-cell lymphoma that affects the skin. It's very indolent, meaning it's not going to kill a lot of people, but the skin lesions can be very, very disfigurative, and they can really cause some problems with morbidity. And they don't smell good. People have embarrassment. They have to wear hot clothes in the summer. It's just a really miserable disease to have. When we talk about hematopoiesis and lymphopoiesis, Dr. Yared will go into this more, but remember, these are your myeloid cells, and these give rise to different types of myeloid leukemias, and indeed each one of these can give rise to a type of myeloid leukemia. Your lymphoid cells over here are the ones that give rise to the lymphomas in general. And when we talk about the lymph node and how it pertains to lymphoid neoplasms, you have to remember that these things come from the specific area. So if you're looking at a diseased lymph node, the germinal centers that are going to develop a follicular lymphoma, are going to be expanded follicles. Whereas if something comes from the center here, it's likely going to be T-cell lymphomas, meaning that the peripheral zone is going to be expanded and the little follicles are going to be squished, for lack of a better word, right? So based on where these things come from in a lymph node, you can actually look at a lymph node and tell what kind of lymphoma it is. So that's kind of a brief overview, and I'm sure Dr. Yared will fill you in more, and I'll answer any questions in the review or email.